Okay, so we'll start off with the first lecture on angiogenesis and vasculogenesis, the concepts and its applications. And it's not by chance that we choose this as our first lecture. It's the most difficult lecture because not so much of the topic itself. The topic is something that you will, I think, quite easily understand. The problem of this lecture is that it seems at the beginning very far away from our daily routine. We are coiling aneurysms, we are embolizing AVM, so why should we care about angiogenesis and vasculogenesis? What I try to tell you with this lecture is that may it be that it at the beginning sounds very far away from our daily routine. We will learn that we will use this more and more when we go into understanding and conceptualizing vascular diseases. And this is one of the parts that Pierre always tried to stress, that we have to understand what is beyond the lumen, i.e. What is beyond the disease. We always try to make us understand why disease is formed. I think therefore that this concepts of vasculogenesis and angiogenesis will be important. In my lecture I will first discuss a little bit about the definitions. What is vasculogenesis? What is angiogenesis? We'll have to discuss about growth factors and their roles. And then we'll go in depth into what vasculogenesis and angiogenesis is. We'll speak about the angiogenic switch and why it is of importance. And then in the last part of the talk, this will be the major part, we will talk a little bit about the applications. Why is it important that we understand vasculogenesis and angiogenesis? So we start off with a couple of definitions. Vasculogenesis is the first step in forming a vessel, i.e. we have the constitution of endothelial tubes de novo, which means that prior to vasculogenesis we just have some progenitor cells, and then due to the vasculogenesis we'll start the formation of endothelial cells, and then in the second step, i.e. from the formation of the endothelial cells and formation of the first tubes, the constitution of a complete arterial network. This is the second part, which means that this is the angiogenesis. So angiogenesis therefore means the formation of new blood vessels from pre-existing ones. So for the vasculogenesis, there are no prior cells, there are no prior tubes, there's just no progenitor cells. And for the angiogenesis, you already have to have existing tubes. Which means that in all of us right now, that we are adults, we still have angiogenesis, but there will be very little of vasculogenesis going on unless we are having, for example, something like an endothelial tumor or some form of tumor that needs new cells. In vasculogenesis, endothelial cells differentiate and proliferate into a primary avascular tissue. They then coalesce, i.e. they grow together and they form those tubes. And this first tubular network will be then remodeled in a process that is called angiogenesis. And this remodeling is also called pruning, i.e. some of the vessels will go away and will be pruned, will be taken away. Some of the vessels will enlarge and grow, depending on whether we will need those vessels or depending on whether there is no need for these vessels. And then the vessels have to constitute themselves, they have to mature, which means that we not only have now endothelial cells, but we have to have supporting cells surrounding the endothelial cells. These supporting cells, for example, the smooth muscle cells, are forming like a secondary layer around the primary endothelial tubes, and these secondary layers are then important for the maturation. This means that the endothelial cells have to integrate themselves with smooth muscle cells and pericells. And then we get further along as we grow, as our body grows, we'll have to have angiogenic sprouting, which means that from the pre-existing vessels, we have to have new vessels forming, and this formation has to go through a destabilization process, which means that the vessels that are already stabilized now have to form some sprouts, and in order to form some sprouts, they first have to destabilize to grow into the previous avascular tissue. All of these methods, all of this angiogenesis and vasculogenesis will be mediated by growth factors. So we now have to talk a little bit about the specific vascular growth factors. And here we have three different families of growth factors. We have the vascular endothelial growth factor, VEGF. We have the family of angiopoietins, and we have the family of efferents. In addition to these growth factors that work on the endothelial cells, we also have growth factors for the non-endothelial cells, i.e. the TGF-beta and PGF, platelet-derived growth factor dependent cells. These growth factors have to work in a coordinated and complementary manner to form stable blood vessels. If they do not work in a coordinated manner, then you'll get abnormal vessels, and you will see a couple of diseases later on where you actually have a problem of one growth factor being more active than the other growth factor. And one of these examples is actually best shown with a disease that we will discuss about right now when we discuss about what vascular endothelial growth factor is. The vascular endothelial growth factor is the most critical driver of vascular formation. It initiates the formation of immature cells. Immature cells means immediately that these will be leaky cells. Immature cells means that these will be the cells that are, like for example, present within a tumor, where we have too much VEGF, and where we have cells that are not having like a completely formed endothelial coverage, i.e. that will be leaky. This VEGF is therefore important in the very beginning of the vasculogenesis, and it's important for the angiogenic sprouting. VEGF itself is regulated by the oxygen tension in the body. The oxygen tension in the body will lead, especially if you have like low oxygen, to the formation of a paracrine secretion of hypoxia-inducible factor, HIF alpha, and HIF alpha will then activate the VEGF. So the first portion of the cascade is we have avascular tissue, the tissue needs oxygen, the oxygen level is low, HIF alpha gets up, and this will lead to VEGF increase. If you only give into a tissue VEGF without the other growth factors, you will have leaky, immature, and unstable vessels, which will immediately tell you what the other families of growth factors do, i.e. the angiopoietins and the efferents. These other growth factors will actually lead to the formation of the then mature vessel walls. If you have, for example, mice engineered to lack VEGF receptor, which is the same as if there was no VEGF in this mouse, then you will have mice that will actually fail to develop vasculature, that have very few endothelial cells, and of course, this is a lethal type of mutation. When we talk about retinal vascularization, I think this is the best example for you to understand what VEGF does and how VEGF is working. You have initially a vascular retina, and now this avascular retina needs oxygen. The oxygen can no longer come just from like the outside world, it has to come there through vessels. So therefore we have HIF increase, and this will increase the VEGF expression. If you now suppress this HIF by putting the patient, or like putting the mice, in this example, under a hypoxic condition, then you will have a cessation of vessel growth because you don't have any longer VEGF. There is enough oxygen, therefore HIF is under-regulated, and therefore we don't make any vessels. VEGF is very low. And what will happen next? When we return to normoxia, the endovascular retina is now hypoxic, VEGF will increase, and then you'll have angiogenesis with leaky vessels. So this is the reason why if you have a newborn child, who is in the ICU, who is getting hypoxic therapy, while these patients will be blind, because they will have lots of hemorrhages. Why do they have hemorrhages in their retina? Well, because they have only leaky vessels. Why do they have only leaky vessels? Because they had no vessels at all during the hypoxemic period, because this repressed the retinal VEGF, so therefore there were too little vessels first in the retina. Now you're getting the child back into normoxia, the retina gets hypoxemic, therefore you get HIF increase, and therefore you have VEGF increase, and now you have all those leaky vessels that start to bleed. So this is the reason why these immature or newborns under hypoxemia often get blind. So, VEGF makes vessels, but these vessels are not mature. Now, what do the angiopoietins do? The angiopoietins are the partner of VEGF. We have different receptors that are only on the endothelial cells, and we have two different angiopoietins, angiopoietin 1 and angiopoietin 2. And again, you can engineer mice that lack one of these angiopoietins. So if you have mice that lack angiopoietin 1, you have a normal primary vasculature, because the normal primary vasculature is VEGF dependent. But there's a failure to associate the primary vessels with support cells, i.e. with your smooth muscle cells and with your pericytes. And therefore, you have a missing remodeling of the primary vasculature, i.e. you will just have leaky cells, only VEGF-dependent cells. On the other hand, if you have an overexpression of angiopoietin 1, then you will get a hypervascularization with increase in the vessel size, but not the vessel number, because the vessel number, again, is related to VEGF. And there will be an increase in the number of vessels, and these vessels are resistant to leakage. And this could be of interest when we will speak about certain AVMs later on and potential treatments of AVMs. We will see that there's some work being done at UCSF by the group of that was previously led by William Young. We have angiopoietin 1, which is the stabilizer, and then angiopoietin 2 is actually the exact opposite. It's a destabilizer. Why do we need a destabilizer in the formation of vessels, in the maturation of vessels? We need a destabilizer because sometimes the vessels need to grow, and prior to growing, you will need to make them actually regress to get into a more early stage and then be able to form sprouts. So angiopoietin 2 allows the endothelial cells to revert to a more plastic state that will either lead to regression of vessels, pruning, i.e. you don't need this vessel any longer because there are enough vessels in this tissue. And this pruning happens in the absence of VEGF, because obviously the VEGF is again regulated by the oxygen level. Or it will lead to the formation of new vessels in the presence of VEGF. So it will lead either to pruning, taking off some of those vessels, or formation of new vessels, depending on the VEGF status. So therefore, angiopoietin 2 is either related to pruning of vessels, cutting vessels, taking vessels away, or to the initiation of angiogenic sprouting, destabilizing the vessels so that new vessels can form. The angiopoietins, therefore, have a major role of blood vessel maturation. It induces the remodeling and the stabilization of vessels through interactions with the extracellular matrix, and is therefore maintaining the stability of the mature vasculature. The third group of growth factors that work on the endothelium are the efferents. The efferents are involved in establishing or determining whether you have an arterial vessel, or a venous vessel, or lymphatic vessels. So they identify the structural integrity of a specific vessel. They will say whether this vessel will become an artery or whether it will become a vein. B2, Ephrin B2 is an arterial marker, Ephrin B4 is a venous marker, which means that vessels, blood vessels, are not just simple pipes, but they are molecularly defined targets. An artery will always be a different target, an artery will always be a different cell type compared to a vein. And therefore you will get diseases that purely hit the arterial side, or you will get diseases that purely hit the venous side, or purely the lymphatic side, or that are somewhere in between, at the arteriovenous junction. Ephrins regulate the interaction between the smooth muscle cells and the endothelial cells, and it's interesting that the receptor of the ephrins also participates in the guidance of axons, i.e. the radial glial, and therefore the CNS development. And this may be one of the reasons why sometimes you have associated AVMs with disorders of cortical development, or you have a DVA with a cortical dysplasia, or in certain forms of migration disorders, such as band heterotopia, you will get abnormal vasculature. So this is why we have an interaction between vessels on one side and the formation of the brain on the other side. And things are of course more complicated than just having one vascular endothelial growth factor and one receptor for VEGF, one ephrin and one receptor for ephrin, one angiopoietin and one receptor for angiopoietin. But we have multiple receptors, multiple vascular endothelial growth factor, A, B, C, D, multiple angiopoietins and multiple receptors that work differentially. But the overall thing that you'll have to take with you and that you'll have to remember for the rest of this course, hopefully a little bit longer, is that the VEGFs are important for vasculogenesis, that the angiopoietins are then important for the proliferation and the maturation of your secondary vessels. So we talked about what is vasculogenesis, what is angiogenesis, we talked about the growth factors, and now we dig a little bit deeper into what exactly happens during vasculogenesis. In vasculogenesis, we first have no vessels. They are just primordial cells. We have hypoxemia, VEGF increases, and now endothelial cells differentiate and proliferate within a primary avascular tissue. They coalesce and form a tubular network between the primary artery and the primary veins that are determined by the ephrins. Now, this happens at a very specific place in the body. It happens at the level of the mesoderm for the heart and blood vessels, at the level of the ectoderm for the neural plate and the neural crest. In between the ectoderm and the endoderm, we have the mesoderm. And from the mesoderm, we have specific cells that segregate from the mesoderm and that start to migrate. They form the primordial vascular cores, and these primordial vascular cores will coalesce and differentiate into primary endothelial cells. These will form tubes, and these tubes will then form a primary vascular network within the mesoderm. And here's an example of this. You can see here the neural tube. You can see here the mesoderm. Here we see an earlier stage when we have the neural crest, the ectoderm that will form the neural tube. And in between the ectoderm and the endoderm, we have the first cells that will form endothelial cells. And this vessel formation is promoted by endoderm and it is inhibited by ectoderm, which means that the cells, the primary cells that form the vessels, will actually be close to the endoderm and distant from the ectoderm. The pharyngeal endoderm expresses HIF-1 alpha, i.e. it is activated under hypoxemia, and this, again, as I told you previously, will initiate VGF. So where is this happening? It is happening close to the endoderm. We have again here the neural tube, the neural crest. We have close to the endoderm VGF increase, and this will lead to the formation of blood vessels. And the formation of blood vessels is important, or one of the regulators here is notch 3. Now, where do we know notch 3 from? Where or in which disease do we have a mutation in notch 3? Cadacil. Okay, so in Cadacil, we will have a problem of notch 3 because in Cadacil we have degradation of the periocytic coverage of those cells, and this will lead to small vessel disease, which will lead to multiple strokes. So therefore, by understanding that notch 3 is already present here in the very early beginnings, and what it is related to, i.e. the formation of vessels, you can understand why patients who have a notch 3 mutation will determine or will become microangiopathic at a very early stage, i.e. will become will have multiple infarctions. Now, once the bilateral dorsal aorta becomes molecularly distant from the first veins, this happens before blood circulation, before angiogenesis, like just after vasculogenesis, and this is related to, again, the ephrins, notch 3, and the veins are ephrin B4 positive versus ephrin B2. Now, the origins of the arteries and the veins is different in the brain from the normal or rest of the body. The arteries of the rest of our body only come from the mesoderm, which makes the endothelial cells, the pericytes, the smooth muscles, and the connective cells. But in the head and the face, whereas the mesoderm still arrives from the endothelial cells, your smooth muscle cells and your pericytes are not coming from the mesoderm. They are coming actually from the ectoderm. And again, this has multiple implications. One of the first implications is that you simply cannot compare the blood vessels of your heart, the blood vessels of your limbs, with the blood vessels of your brain. They have different origins, and then because they have different origins, they will have different fates. And they will react differently to, for example, stents or balloon angioplasty or whatever. So you cannot say, oh, I can stent the heart, so now I can stent the brain. Of course, you can stent brain vessels, but they will react differently compared to the heart. So we cannot just put them all into one box. This is a tube, this is a pipe, this is an artery, and it will react the same here as it will react here. They have different origins and will therefore react differently. And the other thing that is of importance, because they are derived from the neural crest, the neural crest also makes your brain cells, also makes your cells of your face, which will mean that for certain head and neck vascular malformations, we will have a direct interaction between the blood vessels and an interaction with your normal cells of your body. So this is why, for example, you get a syndrome such as phases, where you not only have hemangiomas, but you can also have, for example, Andy-Walker type malformation of your hindbrain. So, we discussed the vasculogenesis. Now we have to discuss the angiogenesis. In the angiogenesis, you have to differentiate two different types of angiogenesis. The one that happens in the embryo, and the other one that happens still with us, like in the adults. Because our tubes, our vessels, they are not the same like the ones that we were born with. Our cells in the body regenerate, and so do the cells that form the arteries. So it is like a rule of thumb that your arteries that you have right now will be completely different from the vessels that you will have in 5 to 7 years from now. Which also means that if you have, for example, an underlying problem in one of your endothelial cells, then in 5 to 7 years, when this endothelial cell regenerates, becomes a new one, you may have the unmasking of an underlying lesion that you had previously already in your endothelial cells that only comes like later on to actually observational point of view, and we'll discuss about this in a couple of slides. So, vasculogenesis was differentiation of endothelial cells. Now, angiogenesis is the remodeling. The primitive network is modified, which means that some vessels are going away, are pruned, some vessels enlarge. And this is, again, dependent on VEGF and your angiopoietins. Your angiopoietins, especially angiopoietin 2, will destabilize, will lead to the pruning if there's no VEGF. The angiopoietin 1 will lead to the formation of new blood vessels, i.e. you will have the remodeling of your vasculature. And one of the best examples of this remodeling of your vasculature is present when we look at the pharyngeal arches. This is how the blood vessel looks like in the very early embryonic stage. We have different pharyngeal arches and pouches. But our vessels that we have right now look completely different, i.e. certain arches go away, but they will carry with them the history of what was previously there. And again, I will give you one example for like segmental type of aneurysms where a specific vessel, it is an embryonic precursor vessel, regresses, but since it may have been like defective from the beginning, we will have formation of aneurysms at both sides or at both remnants of these arteries. The endothelial cells are just not inert cells lining the tubes, but these endothelial cells interact with its surroundings, which means that they are involved in the differentiation and formation of the head and neck structures. They secrete endothelins, and these endothelins will be important for the formation of your normal head and neck structures. So if you have a problem with not having one of these endothelins, then you will get severe craniofacial malformations, and you will have problems remodeling the aortic arches. And again, this is presumably what is present when we talk about faces, where we have lots of different arterial malformations or arterial variations, and at the same time, we will have severe craniofacial malformations. And faces is one of the syndromes that we will discuss in greater detail. I think Sirinkara has a lecture on this. So the cells that constitute the face are derived from the neural crest. The cells migrate along predetermined pathways. They are guided by the endothelial cells. They seed their daughter cells along this path. And this path is always the same. Which will mean that for certain cerebrofacial arteriovenous metameric syndromes, like one additional Blanc or Weibel-Mason syndrome, we will have vascular malformations along specific and predetermined pathways. These endothelial cells will form, these neural crest cells will form at the level of the head and neck with smooth muscle cells, i.e. the tunica media, but will also form the bones and the connective tissues of the face. So here we have the fate maps, of specific cells that migrate from the neural crest. They go together with the endothelial cells, they will form the blood vessels, and they migrate along predetermined pathways. And this will mean that we will get certain diseases that will always have the same type of pattern of vascular malformation along a predetermined pathway. How do they interact with each other? How can the endothelial cells induce the formation of, for example, like the head and neck muscular tissues or the connective tissues or the bones? They form this by a method which is called induction, i.e. the neighboring cells instruct other cells to form particular structures. And if these cells that now try to tell other cells to form a specific tissue are diseased, then the secondary tissues will also be diseased. So cells can signal nearby cells to change in specific ways, and this is called inductions. So if you now get everything together, what is the cascade of cephalic vessel formation? We have low oxygen, this will lead to HIF1, this will lead to VEGF expression, this will lead to formation of a cage of the aortic arches around the pharyngeal endoderm, i.e. the pharyngeal arches. Then you will get the differentiation of this primary network into specific cells, and therefore we'll get the formation of your normal head and neck vessels. This was the embryonic angiogenesis. Now what about the postnatal angiogenesis? In the postnatal angiogenesis, it's something that is happening every day with us. It is happening when, if, for example, a tumor grows in us that needs new cells, or if a child grows to become an adult and needs, is growing, therefore it will need more cells, it will need more blood supply. And this is related to the angiogenic sprouting, i.e. from existing vessels, we will have a destabilization process. The destabilization process has now two different phases. If there's no VEGF present in the destabilized vessels, we have regression or pruning of the vessels. If there is VEGF present, then we'll have sprouting from the pre-existing but unstable vessel into the surroundings, i.e. we have sprouting from existing vessels into avascular and hypoxemic tissue. And how does this work? Well, the first step will be that the outer mural elements will have to dissolve, will have to be removed in order for a new vessel to arise from the pre-existing one. Then we will have the directional sprouting, which means that the VEGF tells the vessel where to go, i.e. where we have the hypoxemia. And then we'll have to reform the pericytes, i.e. we have to have, again, after the destabilization, a secondary stabilization of the endothelial cells, and this will reconstitute the vessel wall and therefore will have a specific matrix. This postnatal angiogenesis is governed also by the same growth factors that are important for the embryological angiogenesis, i.e. the same receptors and the same growth factors. There are a couple of peculiarities of your endothelial cells. Endothelial cells rarely divide. Once in 3 to 14 years, on average you can say every 5 to 7 years you have new vessels. But you can induce those cells to replicate very fast, which means that certain vascular tumors can grow extremely fast. And this is now important when we talk, for example, about glioblastoma multiforme and why avastin will work in glioblastoma multiforme, because avastin reduces the level of VEGF and therefore will induce less blood supply in this rapidly growing tumor, and therefore this rapidly growing tumor will not longer demonstrate any enhancement, because we have less VEGF, therefore we have less leaky vessels, therefore less contrast enhancement of the tumor, but at the same time the tumor will also shrink and die because there are no longer any vessels. But it also explains you why in avastin, in glioblastomas treated with avastin, you can have this pseudo response, i.e. you will see that the tumor is still growing but it's not enhancing any longer. It will not enhance because you don't have any leaky vessels any longer, but it may still grow, smaller or shorter. So, and this is here the example, you have a tumor, the tumor is growing, because the tumor is growing, it is now hypoxic, it will increase VEGF, and you'll get sprouting of vessels into the tumor. If the tumor grows so fast that the vessels can't go along, you will have a central necrotic area and a peripherally enhancing area, i.e. leaky endothelium. And now, at the level of the angiogenesis, we will have to discuss the angiogenic switch. The angiogenic switch means that you have to have a switch from the destabilization process into a stabilizing process. Angiogenesis has two different aspects, as I told you. The first aspect of postnatal angiogenesis is the so-called activation phase, i.e. where your basement membrane is degraded, where you have increased permeability of the endothelium because your tight junctions are dissolved. You have the formation of endothelial sprouts, and due to cell division, you have a luminal formation, and therefore, a new vessel is formed. This is the activation phase. This activation phase has to be now balanced against the stabilization phase, or the resolution phase, where this endothelial cell proliferation is stopped, where the basement membrane is reconstituted, and where the endothelial junctions are reformed. And this angiogenic switch is governed by two gene products that are called endoglin and activator-like kinase 1, ALK1. These two gene products stop or change, switch from the activation to the resolution phase. In which disease are these two products missing? Well, in HHT. In hereditary hemorrhagic telangiectasia, i.e. in a disease where we have the formation of abnormal vascular communications, of shunts, of AVMs. So if endoglin or ALK1 are missing, you have an imbalance of the activation versus the resolution phase. This will lead to structural abnormalities of the vessels, i.e. you will have the formation of pathological shunts. And since this thing is now seen in HHT, we may have here now a window of opportunity to understand how AVMs, even the sporadic AVMs, form. And if you now think back into what is the activation phase and what will be the factors that determine whether or not we have the formation of new sprouts, you will understand why VEGF could be a potential target for the treatment of HHT patients, or why specific angiopoietins could be a target for treatment of AVMs in patients with HHT. And I will give you later on an example. So, HHT has a problem with either endoglin or ALK1. These are gene products that are only expressed in endothelial cells, are important for the vascular remodeling. So, I tortured you a lot about angiogenesis and vasculogenesis. Now, I will try to speak a little bit about the applications. We already discussed some of the applications during the lecture, but now we'll go a little bit deeper into the applications of what I just told you. And these are the applications. So we'll go through them one by one. The first one is a very brief summary of what Pierre used to discuss as the etiological classification of brain vascular malformations. If you look at the classical books of Russell and Rubinstein, your normal classification of neurovascular diseases is you have brain AVMs, you have cavernomas, you have capillary telangiectasias, and you have DVAs. And this is a very good classification, but obviously it's oversimplified. What Pierre tried to conceptualize in his classification of brain vascular malformations is that we have the classification that is based on three pillars. The first pillar is the so-called target, i.e. which part of the vascular tree, artery, arteriovenous transition, veins, lymphatics, is activated, or which one is diseased. Do we have a purely arterial disease, or do we have a purely venous disease? And again, arteries and veins are not just simple pipes, but they are molecularly distinct. Remember the efferents B2 for the arteries, the efferents B4 for the veins. And this distinction is happening right after vasculogenesis but prior to angiogenesis. So therefore, artery, veins, and lymphatic vessels are different molecularly defined targets. Just if you look at here how different veins are from lymphatic vessels, you see that there are many different receptors that are completely different. And therefore, you will have diseases that are purely arterial, you will have diseases that are purely lymphatic, you will have diseases that are venous, you will have diseases that are somewhere in the arteriovenous transition. The second pillar that Pierre described was the timing, i.e. when does a specific bug hits the endothelial cell. Is it an early hit or is it a late hit? Is it a hit of the endothelial cell, like when it just is prior to migration, or is it very late, after the cell has already migrated? Remember that the cells that constitute our head and neck vessels are formed from migrating groups that start from very segmented regions, that course along predetermined paths, that seed their daughter cells along their path. And you now have a defect present in a migrating cell. Let's say here we have a migrating cell from the neural crest. We have a defect present, a primary hit. Then this cell will start to proliferate, it will migrate, and it will seed the daughter cells along very clearly defined and predetermined pathways, i.e. you will have a much larger impact as compared to a hit to the cell that is happening very late. Which means that if you have an early hit, you will have a larger impact compared to late hit, where you will have a more focal impact. And if you now compare or put this together in a matrix, you will have diseases that are very focal on the arterial level. You have focal or late hits on the arteriovenous transition. You will have focal diseases that are purely venous. And you will have very early diseases that are purely arterial. You may have early diseases that are purely venous and on the arteriovenous transition. And we will populate this matrix over the course of this entire course, obviously. The third pillar that we have to discuss is the type of the trigger, i.e. do we have a purely genetical trigger or a purely environmental trigger? Environmental trigger, for example, vascular trauma. Purely genetical trigger, for example, HHT, where we have one single gene that is defective. And of course, in between, we may have diseases that have a significant role of genetics, such as polycystic kidney disease, or diseases which have a significant role of environmental triggers. And this now allows us to put a third dimension into the matrix, i.e. arterial focal diseases that are genetically determined, polycystic kidney disease. Focal venous diseases that are genetically determined, the CRIT mutations, for example, in familial chordomatosis. We will have segmental diseases and metameric diseases, and of course, this is not a strict rule. It is not that these are clearly defined boxes. You may have transitory lesions somewhere here, you may have transitory lesions here, and it's all a spectrum of diseases, but you have to understand that you will have now a classification that allows us, or that helps us to understand why we have certain venous diseases, certain arterial diseases, arteriovenous transitional lesions, and lesions that are more widespread, like cerebrofacial arteriovenous metameric syndromes, and lesions that are more focal. So, the first application of this talk on angiogenesis and vasculogenesis is therefore this etiological classification of brain vascular malformations. The second application is that we may be able now to understand what we mean with the congenital nature of brain AVMs. When you have a patient who has an AVM who's 60 years old, do you think that this patient was born with the AVM? Presumably not. But presumably he was born with a propensity to develop an AVM. Let me tell you what I mean with this. What do these three patients have in common? Well, obviously this aneurysm ruptured, the AVM ruptured, and this patient who had underlying stenosis has his stroke. So we have these patients at the so-called clinical stage. This is where we as neurosurgeons see our patients, where the malformation has become symptomatic. But prior to this clinical stage, of course, there's a so-called morphological stage. This is where the neuroradiologist will see the patient, i.e. where a lesion is present but has not yet ruptured, i.e. the unruptured aneurysm, the unruptured AVM. So prior to the clinical stage is the morphological stage. And this concept of the congenital nature, this concept of vasculogenesis and angiogenesis will help us, A, to understand how we are going and moving from the morphological to the clinical stage, but also that there is something beyond or below the so-called morphological stage. I will just skip this for the sake of time and actually go to this one here. When we discuss, for example, why a specific aneurysm gets symptomatic, there's a lot of interest about computational fluid dynamics. But computational fluid dynamics is not the full truth. When you understand or think about what shear stress is doing, on the other hand, you will be able to understand why it's important to look at the genetics and to understand which aneurysm, for example, gets symptomatic. We do know that in the endothelial cells, certain genes are expressed or overexpressed in low shear stress situation versus high shear stress situation. And these genes that are activated in low shear stress situations are genes that are important for destabilizing the wall, and therefore may be important for an aneurysm to rupture in the future. So it means that if you look at CFD, you should look what is actually the next step of CFD. The next step will be to understand how the shear stress changes the epigenetic regulation within the wall. So we have to do a better job in selecting patients that will benefit from our treatment. And one of the courses or one of the ways that we can do it by using this concept of angiogenesis and vasculogenesis. And we should not stop with the obvious, but understand that prior to a morphological stage, we have a biological stage, prior to this we have a genetical stage, and prior to this we have what is called a pre-pathological stage. So what do we mean with this? We have a cell, an endothelial cell, with a gene. This endothelial cell has the first positive trigger. And we now have an endothelial cell with a defect. This cell proliferates. Now you have an organ with a weakness. And now due to a secondary or revealing trigger, you will get now the organ with the disease. And this disease will then become clinically symptomatic. So this now explains to you why we think that, yes, AVMs are somehow congenital, but they may not be present at birth. You need a two-hit theory. Let's do the example with HHT. We have a mutation in the endocrine gene, which means that we now have the disease HHT. But not every single patient with HHT has a brain AVM. But they have the propensity to develop a brain AVM, or the propensity to develop the mucocutaneous telangiectasias. Then due to a revealing trigger or secondary trigger, you now have the organ with the disease, i.e. you have your asymptomatic brain AVM. And then the AVM gets symptomatic due to rupture or gets symptomatic with epilepsy. So the congenital nature of AVMs means that they are not necessarily present at birth, but you're born with the propensity to develop an AVM. So you need a causative trigger, you will have an area with a dormant or transmittable defect, and then due to the pruning and the remodeling of the vessels, this will lead at one point in time to an unmasking of this defect. So we understand now the etiological classification, we understand the congenital nature of brain vascular malformations, and it helps us to understand specific diseases and their angiographic appearance. For example, von Hippel-Lindau. What is happening in von Hippel-Lindau disease? You have a loss of the von Hippel-Lindau suppressor protein. Well, what does this suppressor protein suppress? It suppresses HIF, which means that if you have von Hippel-Lindau disease, you will have more HIF, hypoxia-inducible factor. And now you can make this cascade by yourself. What is happening next? Well, you will have more VEGF. You will have more growth and high vascularization, which means that you will have highly vascularized tumors. Will these vascularized tumors enhance? Of course they enhance, because it's VEGF, which means leaky vessels, which mean all of your contrast material will go out. Are these vessels mature vessels? Do they have a very good extracellular matrix? Of course not. Because you only have increase in VEGF due to an increase of HIF. So you will have mainly endothelial sprouts within these tumors. What about cerebrofacial arteriovenous metameric syndromes, previously called Weibel, Mason, or body Deschamps-Blanc disease? Again, we will discuss in greater detail about this. But we will have the combination of AVMs in specific areas, i.e. in predefined areas, in CAMS 1, the midline prosencephalic type, involvement of the midline structures, the corpus callosum and the nose, as in these so-called Cyrano-Bergerac lesions, i.e. if you see a lesion at the nose, you have to look at the brain. Or if you see a midline AVM, you have to inject your external carotid arteries to look for AVMs of the nose. CAMS 2, the lateral prosencephalic type, CAMS 3, the rhombencephalic type, and again we will talk more about CAMS, obviously, in one of the next lectures. Because of understanding of the diseases, we now understand why HHT forms. And here this is the work from Dr. Billian's group on HHT. You can see how AVMs in the mice form. If you have no ALK, i.e. if you don't have like this product that makes the androgenic switch, but you do have VEGF, then you will get AVMs. If you have no VEGF, then there is no cause to form new vessels. And even under the missing or glybular ALK1 is missing, because there is no reason to form new vessels, you will not get an AVM, which may cause or which may indicate why you should, or why Avastin could be, for example, a potential treatment options for certain AVMs. And we do know that it works, for example, at least in liver AVMs. But maybe what should we use is not the VEGF, but actually the angiopoietin, because these are the ones that will lead to pruning. So we did do an endocrine knockout mouse at the University of Toronto as a model for AVMs. And if you knock out endocrine, then you get these abnormal shunts, i.e. direct arteriovenous communications, or nidus type AVMs, i.e. very similar to the phenotypic expressions that we see in patients who have HHT. Here, a young baby with a direct arteriovenous fistula,
Here, a young patient who has a nidus type AVM with a single feeding artery, this nidus of abnormal vessels, and then a single draining vein right here, which was also an HHT patient. And here's the example again from Bill Young's group at UCSF that looked at the injection of avestin that inhibits the formation of brain arteriovenous malformation because you don't have any longer any VEGF, or your VEGF is suppressed. It also explains to you this entire concept about HIF, VEGF, why you have surrounding a brain AVM an area that we classically describe as angiogenic sprouting, or where we say that this is not AVM proper, but just abnormal vessels surrounding an AVM nidus. In a patient with an AVM, you will have shunting that is redirected away from the brain, which means that the brain surrounding a brain AVM will be hypoxemic, which will mean that VEGF increases, which will mean that surrounding a brain AVM, you will have abnormal vessels. But these abnormal vessels are only secondarily induced by the brain AVM. They are not primarily feeding the brain AVM, which means that in a patient with a brain AVM where you have transdural supply, does it make sense to treat this patient through the transdural approach? Well, the transdural approach will at one point in time hit the AVM. But prior to going to the AVM, where will it go first? It will go to the brain tissue that has cried for help. It will go to the brain tissue that is hypoxemic, that has therefore said, give me VEGF, give me more vessels, and yes, so there are more vessels coming from the external carotid artery. And now if you inject your onyx, at one point in time you will get to the brain AVM, but you first go through the area of normal brain tissue that has cried for help. If you look at this AVM, is this AVM tissue? Should we include this in our radiation plan? No. There's no early draining vein coming from here. This is just the reaction of the brain to the hypoxemia. So the true nidus is way smaller than this. Another example here, my favorite example. How many arteries are feeding this fistulous AVM? It's a classical workshop case. And in order for you not to start sleeping, no worries, the lecture is nearly over. How many vessels are feeding this AVM? Who's in favor of 1? Who's in favor of 2? But at first you would think this vessel here and this vessel here is feeding this fistulous AVM. But now look at the 3D reconstruction. You see that this vessel here clearly goes directly into the shunt. But this vessel, the lower vessel, goes through an abnormal network of vessels, gets smaller, 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 and then larger, 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 and hooks up to the other artery. It hooks up through this network to this artery. And why does it hook up? Well, because the brain tissue that should normally have been supplied by this artery is hypoxemic, because all the shunt, all the blood is sucked into the AVM. And therefore you have surrounding this AVM local area of hypoxemia, HIF, increases VEGF, increases sprouting of new vessels. And now I hope you understand why angiogenesis and vasculogenesis are of importance to understand your daily practice. Another example here, does the ACA supply this AVM? At first you may think, yeah, sure, because I see an early draining vein here. But look very carefully at the distal pericallosum. You see the leptomeningeal collaterals being activated. You see vessels getting smaller, 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 and then larger, 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 hooking up all to this distal MCA branch that then goes into the AVM. So this is not part of the AVM. but it is part of what you can now understand after having heard and having been tortured by vasculogenesis and angiogenesis. Finally, the last part of the application is understanding complications. Here's the brain area fed by the ICA right here. This is the microcatheter position, far too far proximal. The blue injection was a ligation embolization, i.e. the AVM is no longer there, but I didn't, or in this case here, the blue did not reach the vein. So what will happen with this patient? It will recur. And why will it recur? It will recur because now we have local hypoxemia. This local hypoxemia will lead to VEGF increase, will lead to new formation of vessels, and since the structural network of the AVM is still present, it will finally hook up to the AVM again. And this is the follow-up control here. After 3 months, you now see that the AVM is reconstituted by a fine network of abnormal vessels that now come from the SCA that have been activated due to this effect. Arteriovenous malformations of the face. If you do a ligation embolization, you will increase the VEGF, you will increase like local hypoxemia, and then you will have like reconstitution of the AVM through an abnormal network of vessels. So therefore you can understand why you always have to perform not only ligation embolization by understanding the concept of vasculogenesis and angiogenesis. And with this, I conclude. Remember, and this will be a recurring theme, that vessels are not just pipes that need plumbing, but that we have complex biological systems that need treatment focused on the cause of the disease rather than a symptom. You will hear more often than not in many lectures during this course, aneurysms are a symptom, they are not a disease. They are the symptom of a potential underlying vasculopathy. AVMs are a symptom, not necessarily a disease. Thank you very much.